Carle combines clinical care, health insurance, and research in a way that solves problems today with an eye toward the future. Supported by a deep philanthropic spirit and dedicated to making life better for as many as possible.
Meeting the ever-changing healthcare needs of our communities, Paris Community Hospital Family Medical Center is now Horizon Health, with the same ownership, management, providers, and employees. Horizon Health provides patient care and promotes wellness to the communities of East Central Illinois.
At HS St. Anthony's Memorial Hospital, we are at work transforming heart care, rebuilding knees and hips, delivering new generations, and focused on providing health care to you. We are HSHS St. Anthony's Memorial Hospital.
Sarah Bush Lincoln Health System, supporting healthy lifestyles, eating a heart-healthy diet, staying active, managing stress, and regular checkups are ways of reducing your health risks. Proper health is important to all at Sarah Bush Lincoln Health System.
Hi, thank you so much for joining us on this episode of Being Well. I'm your host, Keanne Armstrong, and today we are going to be talking about stroke awareness and the latest treatment options with stroke. And joining me today are two physicians. I have Dr. Amrendra Miranpuri from Carle, and I have Dr. Joseph Burton with Sarah Bush. So thank you so much, both of you, for joining me today.
Thanks for having us.
Yeah. So this is an amazing topic to talk about. I think a lot of people are interested in this and learning about stroke and know when and how to take a loved one or what to do if they're suffering themselves. So let's just start off with some basics here. Like, what is a stroke? How do we explain it to folks?
Yeah, so most strokes come in as a blockage in a blood vessel. So you'll have a patient come in where they may have a drooping of their face, they may not be able to get words out, they might have a weak arm. And generally when you see somebody who comes in with an acute, abrupt onset of something like that, stroke kind of makes it to the top of the list, because if that's not identified and treated if possible, patients can have long-term complications from that. And so 80% of the strokes that we see present like that, where it's a blockage of a blood vessel, a part of the brain is not getting blood flow to it, and so they'll have these types of manifestations: the facial droop, arm weakness, speech difficulties, problems with their vision potentially. The other 20% are bleeding strokes. So it's a blood vessel that may have bled into the brain itself. And those patients will oftentimes present with headaches, nausea, vomiting because of the bleed. They're having some elevated pressure in the brain, and so those patients kind of require a different treatment course.
So you're a neurosurgeon with Carle, and you are the medical director of acute care medicine at Sarah Bush. So you both work hand in hand when it comes to dealing with patients with stroke. So we're going to have you talking a little bit more about that portion, what causes a stroke, what is a stroke, and then I want you to talk a little bit about who is at risk, and is it only older people?
Usually it is, and it's patients that have underlying comorbidities or risk factors such as hypertension, diabetes, and depending on how well controlled those disease entities are, that's sometimes what puts people at higher risk for having strokes. People who have underlying coronary artery disease or heart disease are also at increased risk because you can have a stroke by a ruptured vessel or a vessel that has compromised blood flow, or you can have what we call global hypoperfusion. So if your heart doesn't work well, and if you have low blood pressure, or if you go into shock because of blood loss, or because of an infection or a heart attack that's massive, those things can also put you at risk to have a stroke because of just generalized decreased blood flow to your brain. And depending upon what part of the brain is affected, that's what determines how severe the stroke is. And it also, in determining which vessels are injured, that's what kind of drives the treatment therapies that we look at in the emergency department or in any acute setting.
Okay, and what's the typical thing that you see? Does someone bring themselves to the doctor, curious about this and what's happening to them. A loved one maybe calls. What takes place so the people who are watching this will know, maybe what to look for or how to notice if something is happening with themselves?
Yeah, it's variable. Sometimes there are witnesses to this happening. And so, the key with stroke is that it's abrupt. It's not something that kind of gradually takes time for it to manifest. So, you might be sitting there at dinner with someone and all of a sudden they can't talk or they have a facial droop. And so that is a red flag that somebody could be having a stroke. The other situation is where it's unwitnessed. And those are terrifying because you don't know how long that patient's been sitting on the floor.
Yeah.
Maybe they had a weak leg, weak arm, and they fall to the ground. And somebody comes upon them, maybe a family member, several hours, or in some cases where we've seen, a day or two later, you show up to the apartment and you see somebody lying there. So those patients are obviously much different than the patient where you see it happen before you.
When they come into the emergency department, time is of the essence because, someone has really taken heart to seeing, hey, something is very wrong here, this may be a stroke. So you would be one of the first people who would see that patient coming in?
To Dr. Miranpuri's point, there's a group of strokes that occur while people are sleeping.
Oh, okay.
And so they go to bed, they're normal, they're acting normal, they're talking normal, and then they wake up and then they have these deficits and they can't speak or they can't sometimes get out of bed or they're having difficulties. And so the Sentinel Indicator is that a family member either finds them still in bed or hears them fall in the morning. Numerous times we have patients, husbands or wives say, I got up first, I was fixing breakfast, and then I heard a thud.
Oh, okay.
And so currently, and we can talk in more detail about some of this, is that these patients typically, when they woke up with those symptoms, we considered them out of the treatment window for certain options in terms of how we treat stroke. We now have studies that are letting us know that we perhaps have more time than that now, and we can actually potentially treat some of these patients that have had these types of strokes.
Oh, that's good to know.
That's probably one of the best pieces of news that we've had in terms of treatment of stroke, and those studies have been around for a while longer, but the two studies that came out at the beginning of January, February of this year are the ones that have kind of brought more attention to all of this. Dr. Miranpuri is known for quite some time that this treatment option was likely going to work, but these studies, which he can speak to, are the exciting part of the treatment.
Okay. Do you want to expand on that?
Yeah, so one of the things that people probably know about, probably a loved one or a friend in the community, is the clot-busting drug TPA. So this is a drug that when patients come into an emergency room, we have in some patients up to 3 hours from when they were last known normal, and then in other patients up to 4.5 hours. But 4.5 hours is the max. So if somebody woke up with a stroke and they went to bed at 11 o'clock at night and it's 7 o'clock in the morning, if they show up to an emergency department, they are likely not going to be eligible for that clot-busting drug.
Right.
Unless they woke up in the middle of the night and the family member said, yeah, he woke up at 3 in the morning and now it's, and they went back to sleep, and when I saw them at 3 in the morning, they were perfectly normal, but then they went back to bed and now at 5 I saw them not normal.
Right.
So that history is the key to stroke care. We rely on the witness because oftentimes the patient can't tell us reliably what's going on. And this medication, if you give it outside the time window, you're putting the patient at risk of having bleeding in the brain.
Oh, okay.
And it's a clot-busting drug, so it's basically given through an IV, and it finds its way up to the level of where that blockage is in the blood vessel, and it lyses the clot. Not in all patients, but in enough to know that that is the standard of care. So patients who can get that, it's a wonderful option. The other patients that, as a neurosurgeon, I get involved with are the patients that come in with very severe strokes. These are the patients who are basically paralyzed on one side. They have they can't speak. They're looking off to one side, and these patients, when we study their blood vessels through a scan that we obtain in the emergency department, we will see that there's a blockage in the largest blood vessel that supplies the whole half of the brain. And what we know is that clot busting drug, because you're giving it through an IV, it doesn't work as effectively in lysing that clot. And so what we've found is that these patients benefit from an intervention, a procedure where we take a small catheter, wires, balloons, stents, and we take it through an artery in the leg, and we navigate it up through the arteries using X-ray and dye, and then we actually physically remove the clot, because it's such a large clot that the clot busting drug may not work.
Okay.
Now, that being said, everybody who's eligible for the clot busting drug needs to get the drug.
Yeah.
And anybody who's eligible for the procedure to remove the clot physically with a mechanical device needs to get that procedure done. And what we don't want patients to do is we don't want patients to sit at home thinking that maybe this thing will get better over time. If it came on suddenly, it's not something that you've ever had before, you got to get medical attention right away. Because now we do have data that shows that we can go up with catheters and wires beyond the 4.5 hours that the clot busting drug can be used for. We can go up to 24 hours.
Okay.
Last known normal. That's a phrase that we use in the stroke world. But again, we don't want somebody at home sitting there for 24 hours getting the message, well, I can wait up to 24 hours because the doctors say that they have this new procedure and they can do it that many hours out. No, we want you to come in because the sooner, the better.
The sooner the better. Time is always of the essence, it sounds like, when it's coming to dealing with a stroke. So don't wait. That's the biggest thing that you want to get across to people. You need to get treatment right away.
The death rate for strokes in third world countries is much higher than in the United States. And part of that reason is linked to the fact that people have not been educated and made aware that you need to hurry up and get to a definitive place for treatment for stroke. And so those types of patients typically just either stay at home or don't go see anybody. They don't know what's wrong with them. And then unfortunately in those cases, those patients die. So we still have an uphill battle to fight in terms of patient awareness, even within our communities here, because more often than not, we still have patients that show up and they basically, we say, when did your symptoms start? And they say, well, it started sometime day before yesterday, or it started sometime yesterday in the morning, but I just put it off. And then we do an exam and we find out, oh my goodness, you've been having a stroke, but it's too late. You've passed the window for treatment with TPA. What the new studies have done now is opened up the window for treatment for certain types of strokes. It's not for all the strokes, and it's only for a small portion of those types of strokes. But roughly, the literature I was reading was saying maybe somewhere between 10 and 20% of the ischemic strokes perhaps involve large vessel strokes that could be potentially treated by the endovascular intervention that Dr. Miranpuri does.
Okay. So lots of different types of strokes, but just be aware of some of the signs and symptoms that you've mentioned up to this point, and don't sit around and wait. If you're not feeling well or if someone recognizes this, just go to the doctor. Don't wait. So let's talk about how you work together through the treatment with Carle and Sarah Bush and the stroke rehabilitation, and how you work together for the patient's care. Either one of you can.
Let me start.
Okay.
Because when the studies first came out in January, February, we were in the emergency medicine community. We were very excited because the TPA administration for the treatment of stroke has been controversial.
Yes.
There's been a group of ED physicians that felt that the studies initially didn't support giving TPA for strokes. Then there was groups of physicians that obviously supported it, and that has gone back and forth. And it used to be you were at higher risk from a malpractice standpoint to be sued if you gave TPA
Okay.
in the treatment of a
Interesting.
patient. Currently, fast forwarding to within the past 2-3 years, that trend has reversed. You are now more apt to be litigated against if you did not give TPA for stroke. But there's still almost I think the study I read was a 17% chance of you being sued if you gave the TPA and there was a bad outcome.
Okay.
And so it is a sensitive area. And so when the emergency medicine community read these papers and we found out that there was a treatment for stroke that extended the treatment time window and that potentially helped stroke patients even if they didn't qualify for TPA, that was really good news for us and also for the patients, obviously. The other thing that I would emphasize is that Sarah Bush Emergency Department and hospitalists, we have always worked very closely with all the specialists and medical staff up at Carle, because they are the trauma tertiary care center, they are now the tertiary stroke center, and so the things that they have offered and we have enjoyed for the past multiple decades now has been immense, and it's been a good thing for the community, it's been a good thing for the hospital. So Dr. Miranpuri was actually asked to come down and speak with our medical staff, how many months ago?
It's like 3-4
months ago.
Right.
And so he presented the information to our entire medical staff to just make people cognizant of what the treatment options were for this and how it's developing. So it's getting exciting because as all of this starts to develop, the standard of care is also going to change to some degree. So we've actually even begun to prepare pre-hospital wise how we're going to direct patients, because when you have a limited resource of treatment, which the neuroendovascular intervention is currently, because I think the next closest neuroendovascular will be Springfield currently.
Springfield, yeah.
So obviously we have to be careful of, we don't want to send too many cases that may be false positives to these tertiary centers. At the same time, we want to get patients there as quickly as possible and what's best for the patient. So we're trying to now figure out what that balance is, and then I can let Ben take it over.
Yeah, and Dr. Burton, he calls me in the middle of the night about a potential case. We have those images that are being produced at Sarah Bush sent over to Carle immediately. I open up my laptop, I look at the case, he and I talk about the patient, and so we have a conversation, because like he said, we don't want somebody coming from here unless they're going to end up potentially getting something done. There are some patients, their stroke is so devastating that we may not be able to reverse the stroke. That is always our goal. To make them make them look the way they did before they started having these issues. Okay. Those are the patients that we really get excited about. Unfortunately, there are some patients who have very devastating strokes, large hemorrhages in the brain, a blood clot that's been plugging a blood vessel for so long that we will not be able to undo that stroke. And we still have to care for those patients. We have to have conversations with patients' families, be able to explain to them what the next several days, weeks, months will look like. And we always want to respect those patients' wishes using the voice of the family. It's a very tough thing that we have to, we have to deal with on a day-to-day basis, because there's the joys of reversing the stroke, and then there's the sadness of kind of not being able to reverse it. But because some patients, knowing their wishes, would like everything done, we want to get them through that. And they know they're going to have some deficits, and then being able to try to get them to a rehabilitation facility. to get them better as they can get, and still being able to interact with their families. That's always our goal. And so if they come to Carle, we really want to get them back to their community as quick as possible so they can be close to their loved ones.
Yeah, absolutely. I think this is great that we're talking about putting the patient's well-being, their health, above anything else, and you're working together. Is this something that is unique because we're in a rural area, or is this just the way things are merging these days?
I'd say probably a little bit of both.
All right.
But I'd say the fact that we are a rural community medicine scenario, that leads to several challenges that if you're in an urban area, you don't have to worry about. There's more limited resources. The distance to definitive treatment is longer, and depending on what the weather is like, we've had snowstorms where we've had critical patients that we couldn't even get out of Sarah Bush's emergency department sometimes because of that.
Yeah.
And so, again, you have special circumstances that sometimes are that other places don't face because they're not in a rural area. But again, having a good working relationship and good lines of communication, information now going, to Carle for CT scan results and things like this. When I first started at Sarah Bush, if I did a CAT scan at Sarah Bush, that study wasn't accessible by the Carle docs.
How closely related are heart disease and stroke?
First off, they're related because of, like I spoke to earlier, if you have a bad heart attack or if you have poor cardiac function, that can lead to low blood pressure states, which can then put you at higher risk for strokes just because your perfusion of your brain is not as good as a normal person with normal blood pressure. Secondarily, if you have certain types of cardiac dysfunction, such as atrial fibrillation, that can set you up to form clots in the chambers of your heart. And if you have those clots, sometimes those clots can break off and embolize and cause embolic strokes. And so that's a subset of ischemic stroke. Whenever someone has heart disease, it definitely increases your chances for stroke. And so in terms of preventive medicine and preventive things, if you eat right, if you control your blood pressure well, your diabetes well, those things all decreases your chances for heart disease and thereby also decreases your chances for stroke.
All right. Would you like to follow up with that?
Yeah, I mean, there's just a lot of corollaries between heart disease and stroke, like Dr. Burton highlighted, high blood pressure, cholesterol, diabetes, smoking, and we see even patients who have blockages and blood vessels in their legs, and there's kind of this trifecta where you have patients who may be at risk for stroke, be at risk for heart attack, be at risk for having blood clots in their leg arteries, where they're having pain when they're walking. So this is all in a spectrum that's common between these, what we call vascular diseases.
It is very important to get this education and awareness out. I mean, it's critical to let people know the timeliness of what is important. And so to wrap up the program here, we got a couple of minutes left. What would you like to let people know on what's most critical here?
I would emphasize the need that if you think that you're having a stroke, if you're a family member or if you're the patient, it's difficult if you're the patient, but you need to get to see a physician as soon as possible. That would be the number one message that I would deliver.
Okay.
We just had Stroke Awareness Month, and the thing that we were blasting out into the community was this acronym that a lot of people now know actually is FAST. It's very simple. FAST is F-A-S-T. F is for face. So if you see somebody or yourself having asymmetry in your face that comes on all of a sudden. A is arm. Your arm gets weak all of a sudden. S is speech. You're not able to get your words out. And T is time to get help. Okay, so if you have those three things or any one of those three things happening, and that's not normal for you, you need to get attention. And that T is, they'll show like an ambulance on there, but the key there is you're not calling your primary care doctor at 5 o'clock at night hoping they're still there. You're not if you can't move your right side, you're not trying to get through, get into the car and try to struggle into the ED. You want to call 911. And if you see somebody having these problems, you want to focus on that person, and you really want to kind of help get them to definitive care, and not second guess yourself.
So don't drive them, call 911.
Yep.
All right. So, all right, it's been great listening to all this education, the new updates, great information for our viewers out there. So thank you so much for being a part of Being Well today. Thank you. And thank you so much for watching this episode of Being Well. We hope you have learned about stroke awareness. So don't wait, make that call and get yourself treatment. If you need more information about this program, visit our website, WEIU.net, and click on Being Well. Thanks for watching.
Sarah Bush Lincoln Health System, supporting healthy lifestyles, eating a heart-healthy diet, staying active, managing stress, and regular checkups are ways of reducing your health risks. Proper health is important to all at Sarah Bush Lincoln Health System.
Meeting the ever-changing healthcare needs of our communities, Paris Community Hospital Family Medical Center is now Horizon Health, with the same ownership, management, providers, and employees. Horizon Health provides patient care and promotes wellness to the communities of East Central Illinois.
At HS St. Anthony's Memorial Hospital, we are at work transforming heart care, rebuilding knees and hips, delivering new generations, and focused on providing health care to you. We are HS St. Anthony's Memorial Hospital.
Carle combines clinical care, health insurance, and research in a way that solves problems today with an eye toward the future. Supported by a deep philanthropic spirit and dedicated to making life better for as many as possible.